Okay, in the interest of time, we are going to go ahead and get started. Welcome, everyone. Our topic today is stroke, facts and prevention. So it should be a very exciting presentation, very informative, and we have excellent speakers. So before I tell you about them, just a reminder that these complimentary webinars are brought to us through a collaboration of sponsorship that consists of Care Choices, Hospice and Palliative Services, O'Connor Mortuary, Caring Companions at Home, and Alzheimer's Orange County. And I am Kim Bailey. I'm a gerontologist and programs and education specialist at Alzheimer's Orange County, and I'm thrilled as always to be your host today. So, you know, our sponsors provide these monthly webinars as a service to the community on topics that are beneficial for anyone, whether they be a family member or a professional working in the field of aging. All of us are in service to older adults, and we hope that you find today's presentation especially informative and useful. We have Diana Tai, and she is a board-certified acute care nurse practitioner and clinical nurse specialist who oversees the stroke program at Mission Hospital. Diana began her career in neurocritical care at Hoag Hospital over 12 years ago. During her time at Hoag, she moved into the role as a critical care CNS. She worked on numerous hospital protocols and policies involving bedside tracheostomy, post-cardiac arrest management, ABCDEF critical care bundle, multidisciplinary team rounds, the telecommand center, and many more. Her clinical background also includes being part of the rapid response and sepsis team. Diana recently joined the Mission Hospital family to help develop and collaborate with Mission Neurosciences Institute in order to obtain and maintain the Elite Distinguished Joint Commission designation of Comprehensive Stroke Certification status. Her work with clinical experts such as Dr. Joey G. and Mary Kay Bader has led to outstanding patient outcomes for stroke patients. Diana was born and raised in Maryland, where she obtained her Bachelor of Sciences in Nursing at the University of Maryland, Baltimore School of Nursing. She later moved to California in 2006 with her husband, Dr. Kenneth Tai. While raising two wonderful kids, Addison and Adam, she attended California State University, Long Beach, and graduated with honors with a master's degree in nursing and subspecialty in adult health CNS and adult geriatric acute care MP. She is also clinical faculty at Cal State Long Beach for the nursing program. Her time is primarily dedicated to increasing stroke awareness and recognition in the Orange County community. So we look forward to hearing from Diana. And then our other speaker, our principal speaker today is Dr. Rahim. Dr. Basit Rahim joined the Comprehensive Stroke Center at Mission Hospital in 2019 as the Neurocritical Care and Stroke Medical Director after completing his Neurocritical Care and Stroke Fellowship at Stanford University in Palo Alto. He oversees the care of patients who are neurologically critically ill. As the medical director, he's actively involved in expanding the stroke program. His past research and current academic interests are in the acute management of large vessel ischemic stroke, hemorrhage, and I'm so sorry. You're going to have to explain these terms to me, doctor. And quality improvement in stroke management. Dr. Rahim is an active member of the Neurocritical Care Society and has been serving on clinical quality improvement committees at Mission Hospital. He currently resides in Irvine with his beautiful wife and two children. And so, Dr. Rahim, can you turn your webcam on and tell me how to pronounce those terms, please? We are so thrilled to have you and Diana with us today. So I want to invite you to join us at this time and we'll begin your presentation. Oh dear, I hope he hasn't been called. I was afraid you two had been called away for an emergency. We know you're probably on call 24/7, right?
Majority of times, yeah.
I'm going to go ahead and turn it over.
Yeah.
Turn it
So
over to you.
just intraparenchymal hemorrhage, it just means bleeding in the brain, and subarachnoid hemorrhage is a different type of bleeding that's around the brain. Overall, that's the umbrella of stroke. So, but we're technically going to be talking about a ischemic type of strokes. And with me here is Diana Tai, who, we had like 2 lovely paragraphs about. So, so my as Ms. Bailey introduced, I'm Dr. Rahim. I'm the medical director for stroke and neurocritical care at Mission Hospital, and right next to me is Diana Tai. She's our stroke nurse practitioner, and also the overall to-go person for the stroke program here. She takes care of pretty much everything. So I have no disclosures. So a little bit about Mission Hospital. We are about 523 licensed beds at 2 campuses, includes Laguna Beach and Mission Viejo, which is our main campus. And we're also a comprehensive stroke center. What that means is that we are capable of handling any type of stroke patient, no matter how complex it may be. And we are the largest medical facility in Orange County, and we do treat about 80,000 patients annually. We are a stroke receiving center, which is part of a comprehensive stroke center, and we go through this rigorous process of getting certified. So we are a joint commission certified comprehensive stroke center, which means that we go through a rigorous process of getting that certification every 2 years. We have to meet particular quality measures to get that certification, and we've gotten it multiple times. And actually, not only that we've achieved the minimum, actually we've gotten multiple awards for being the best actually in the county, which is the Gold Plus Award, which is listed here. We did achieve that in 2020, and we expect to achieve that in 2021 as well. It's just not represented in this slide. Okay. So just a little more stroke facts. So one American dies every 4 minutes of stroke. So it is a very big part of any community. There's in our hospital, while we're doing this presentation, you'll probably hear a stroke code in the background, or code blue. I am in my office, so it's very common to have multiple strokes that we have here at Mission Hospital. And it is the 5th leading cause of death in Americans, and it's also a leading cause of disability. Now, stroke used to be one of the leading causes of stroke in 1 and 2, but with the research in the last 20 years, we've gotten that down to 5th or 6th at this point. So with it, this is a very growing field in neuro that we are ability to treat stroke patients quite effectively, and so they can be discharged and go back to their loved ones with least amount of disability or no disability. So what is a stroke? So these 2 pictures here illustrate the 2 main types of stroke. The left one represents an ischemic stroke, and that happens about 85% of the time. That, let's say, if a patient comes in, and basically what the picture shows here is that a clot is coming up, and one of the branches of the artery, the clot will go until it stops, like basic plumbing, and basically will cause lack of blood flow to the rest of the brain that supplies that supplied by that artery. So that brain will suffer an infarct, which basically means lack of blood flow, and cause damage to that area. So that's a blood clot. Either it comes from the heart or the carotid artery, or even from the legs. That can occur. So that's majority of the strokes that we see. But 15% of the strokes that do come in are hemorrhagic. What that means is just bleeding in the brain. And we see here in this animation that this red represents an artery, and that artery unfortunately bursts in the brain and causes leaking within the brain, and that can cause neurological injury. So those are two different types of the strokes, major strokes. Okay, and in the hemorrhagic strokes, we have bleeding in the brain, on the outlying parts of the brain, and also sometimes just below the scalp. So there's different types of hemorrhagic strokes as well. So how do we recognize symptoms of stroke? So it actually depends on what part of the brain is injured. If it's a large enough stroke, then you have the universal signs of weakness and trouble speaking. And symptoms are referred to as negative symptoms, meaning you have a function, but it's taken away by that stroke, and it's called negative. So it's something that we take away, like if you're able to speak and now you're not, that's called aphasia, and that's a negative sign. And because in that animation that we looked at, a clot will stop blood flow instantly, so the symptoms are quick onset as well. And the majority of times, the patients that come in will have speech difficulties, trouble with strength in one arm or leg, or usually it's one side, balance or dizziness, depending on where the stroke is, vision, changes in sensation, and possibly a headache. Headache is mostly associated with the bleeding type of stroke. So those are things that you want to look at when you're taking care of a loved one or a family member. That is the speech okay, strength, weakness, sudden onset of vision loss, or a headache. Headache that they never had before. Those are classic signs of stroke. So what are the risk factors for stroke? And there's modifiable stroke risk factors, and there's non-modifiable stroke. Modified risk factor just means something that I can look into and control. And some are very risky to treat, some are very common, and some can be treated easily. The slide says patent foramen ovale. That's a fancy term saying a small hole in the heart, which is here. Okay, you see this in the image here. That means, this is a illustration of the heart. A clot may come from the leg, and if you have an opening in the heart, which 20% of people do, that's not abnormal. But sometimes it can actually go to this side of the heart, and this side of the heart is actually connected directly to the brain, actually, and the rest of the body. So that can actually go up to the brain, and that we can actually, if you have developed a stroke from this, we can actually close that surgically. So that's a modifiable, something I can do about it. There are other factors that can change, that cannot be changed, which is age, race. So every ethnicity or race will have a different risk factors about stroke, genetics, and clotting disorder. Some people do have clotting disorders. They can get clots much faster than other people. Unfortunately, these are something that are not modifiable. We can decrease risk overall, but some of these factors cannot be changed. So hypertension, also high blood pressure. So regular blood pressure screening and appropriate treatment, including both lifestyle modifications like diet control or medications, are recommended. Now, we like to see systolic, which is the higher number, less than 140. That overall will decrease your risk for stroke if you don't have any blood pressure issues. Now, it's one of the major risk factors is high blood pressure. And we do see a lot of stroke patients that come in and they just haven't had treatment for their high blood pressure. They just ignored it, or they just didn't want to go to the doctor. Unfortunately, with age, high blood pressure is very common. And so having your blood pressure lower than the systolic, which is a higher number, the top number 140, and then the diastolic blood pressure, which is the bottom number, less than 90, reduces your risk for stroke quite significantly. So that is something that we can control, and it's a major risk factor for stroke. Okay. Smoking is it's also a modifiable risk factor. Now, smoking overall, if it's 1 cigarette or 10 per day, it usually has the same effect. What happens when you smoke is it produces inflammation in the body, reduces the oxygenation, increases the clotting mechanism. It basically, your organs are sustaining that injury, so they age rapidly, and it lowers your good cholesterol, and it increases your blood pressure. So you can see all those 6 tabs there that smoking does, and all of them collectively will increase your risk of stroke. So what happens is that your blood vessels detect this inflammation and tries to kind of protect itself and creates these plaques around the arteries, which you'll see like a illustration here. So once this plaque formation cycle starts, it's very hard to control. And we have to approach this plaque formation on multiple different pathways to reduce that. And smoking is a good way to start. Diabetes. Diabetes is a disease that pretty much affects every part of your body. Nerves in the legs, in the arms. It affects your liver, mouth, kidneys, everything. So, but because it's a stroke presentation, I want to concentrate a little bit more on the stroke. So basically, just as much as smoking, diabetes also takes a toll on your blood vessels. Blood vessels are important to provide blood flow to the brain and the oxygen. And if you have uncontrolled diabetes, then those blood vessels also are stressed to some amount, and they can promote inflammation, and the inflammation starts a cycle where the arteries get more hardened over time, and eventually those arteries will reduce blood flow and then eventually end up with a stroke. Lipids and cholesterol. So we've heard of all the bad cholesterol, which is LDL, and there's good cholesterol, which is called HDL. So LDL is what's studied in stroke. LDL is reduced by, it's a modifiable risk factor, and you can control it by diet and with medication. And to get that number low, it's a must, especially with stroke patients. So you know how that inflammation starts with smoking and diabetes. You have the cholesterol that accelerates that process. The cholesterol itself, if you have so much amount of cholesterol, it will stick to the blood vessels and cause plaque. And we have particular medications called the statin. You've probably heard of it, Lipitor and Crestor. These are major medications that actually help us counteract the effects of cholesterol and prevent stroke, actually. So a lot of cholesterol medication will have side effects like muscle pain and stuff like this. We will look at that overall profile of the patient, the risk factors, and see what the risk and benefit of starting those medications are. Okay, but statin is a very important part of treating stroke. So back to modifiable risk factors, atrial fibrillation is a major risk factor for stroke. A lot of people may know what atrial fibrillation is, but sometimes, I'm just going to go over it a little bit more. So atrial fibrillation just means abnormal heart rhythm. And you see here in the presentation here, this is the top part of the heart, the top two chambers, and these are the bottom two chambers of the heart. These are called the atria, and this is called the ventricles. Now, the atria, basically, the normal conduction of electricity from the heart starts from this area, the top part, and it goes down and causes the heart to contract. But in atrial fibrillation, you have just uncontrolled pulsing electricity up here from the heart. It can occur from stroke or just, as the heart ages, it can produce atrial fibrillation. Now, what happens is that when you have abnormal rhythm in the heart, you can produce some reduced flow of blood out the heart. And when you leave blood in a particular place, it clots. So it can clot in a little area in the heart and potentially cause that clot to go up to the brain and cause a stroke. So atrial fibrillation that is not treated or goes undetected is a major risk factor for stroke. And a lot of people will feel abnormal heart rhythm, palpitations, and usually it's detected without the incidence of stroke. But sometimes a stroke is the first scenario where we'll pick up our atrial fibrillation. And when we do pick up atrial fibrillation, that's a abnormal heart rhythm. Cardiologists get involved and they may assist with preventing the amount of atrial fibrillation burden a person may have. However, because we know that a person is capable of going into atrial fibrillation, once we detect it, then we start more powerful blood thinners called either warfarin, dabigatran, rivaroxaban, or apixaban. This is Eliquis and Xarelto. You may have seen ads for those on TV. These are more powerful blood thinners beyond aspirin that if blood were to pool on one side, then it's not easy to coagulate and then cause strokes. So these medications in the setting of atrial fibrillation reduce your risk for stroke quite significantly. They're not 100%, but if you have atrial fibrillation and you're on these medications, then it reduces quite significantly. Okay. So we look at a few different factors. Sorry about that. So we look at different risk evaluations to look at which patients do we need to treat for atrial fibrillation, and we calculate the score. So I present the score here not as something that you need to memorize or anything like that, but I look at atrial fibrillation without any of these other factors is a lower risk for stroke. However, if you have atrial fibrillation and you have congestive heart failure and you have hypertension, your age is greater than 75, and you have diabetes, and you've had a previous stroke, your risk for stroke goes up quite significantly. Now, what this is our research from many stroke research has provided this, but recently we've upgraded it to more extensive scoring, which adds basically same thing here, but adds vascular disease. Like if you have history of heart disease as well, we'll give you that will increase your risk. Age 65, 74 will increase your risk as well. We gave 2 points for above 75, but we only give 1 point for 65, 75. And then female risk at above 65, females and males actually have similar risk factors, and actually females become more susceptible to stroke as they age. So we give a point for that. So collectively, this score just tells us, do we need to start you on blood thinners or not? So we talked about the anticoagulants, which is the more powerful blood thinners called warfarin and Pradaxa, Eliquis, and Xarelto, and these reduce your risk of stroke quite significantly. And if you don't have any contraindications or any adverse events from these medications, or you don't have any bleeding anywhere, then these are medications that are highly recommended for atrial fibrillation. And if you see a stroke neurologist or any neurologist in the community and you have atrial fibrillation, they will present you with taking one of these medications, or your loved ones. So another thing we look for as stroke doctors is basically we look at carotid disease. So carotid disease is very prevalent in the United States. And here in this picture, this is just an angiogram. You know, a lot of people get angiograms of the heart. We also do angiograms of the brain. And we look at this artery, and it's called the carotid artery. And here you see how it narrows. We call this a stenosis. And basically in this, you know, you can see that blood is flowing, but because there's a narrowing, there's decreased blood flow further down, and that can lead to a stroke. So sometimes this can be treated by stents or with surgery. We have to look at risk and benefits of both procedures. And if it's not too much, we may just give you blood thinners like aspirin and Plavix, maybe even warfarin, depending on how tight this scenario is, and that's to reduce the risk of stroke. So blood thinners is one way to approach it. Asymptomatic just means that it hasn't caused a stroke, so we just give you blood thinners to prevent any worsening of that. But if you become symptomatic, meaning that blockage has caused you to have a stroke, then we do surgery. And that's a CEA, carotid endarterectomy. It's fancy of saying just surgery to basically take that area out that is causing the narrowing. Or stent, basically what we do is we introduce a catheter here, and then we basically deploy that catheter outwards so it holds the artery open. And also modifiable is physical activity. So physical activity, exercise especially, will reduce your blood pressure and help with your diabetes. It reduces obesity, which is also a cofactor in assisting, accelerated stroke, and then improves your sleep as well. So I want to talk a little bit more about risk factors for stroke. We talked about the major ones: high blood pressure, cholesterol, diabetes, smoking, and exercise. These are things that we as patients and community members can actually do to reduce our risk for stroke. So the other factors that I also look into for my patients is sleep apnea. So if you have sleep apnea at night, you have reduced oxygenation at night, and that can also reduce to stroke over time. Migraines is also linked to higher incidence of stroke. Migraine is a vascular event. It can cause shifts in blood flow to the brain, and that can increase your risk for stroke, but not significantly. And we have hormone replacement therapy. Now, hormone replacement therapy actually does increase your risk for clotting. And I see a lot of young individuals that may be on testosterone, and they end up coming in with strokes. It doesn't increase it quite significantly to have its own slide, but it's something that I do want to mention. And substance abuse over time will cause increased risk of stroke, and excess alcohol as well. So we talked about all the risk factors for stroke, and I wanted to go into a little bit more about treatment. So a lot of people may think about, we talk about time is brain. So the faster you get to the hospital, the more options of treatment that we have. And one of the medications that we give during stroke is called intravenous alteplase, or in short, we call it TPA. And this picture here, basically we give the medication, and the medication is actively reduces the amount of clot that you may have. So if you see this clot, this medication is reducing the size of it, and then it will reduce this clot underneath as well. Now, so that is something that we can only give up to three hours in some situations, and up to 4.5 hours in certain situations. So it's very important to come to the hospital right away when symptoms present. So after 4.5 hours, unfortunately, it's not FDA cleared for me to give. So unfortunately, we cannot give medications, the TPA medication, for people that present more than 4.5 hours. Now, thrombectomy is another term here. That's just saying that we go in, we introduce a catheter through the groin area to one of your blood vessels, and we take that catheter all the way to the brain. And that's what the catheter or the stent looks like. What we do is we take that stent into the area where that clot is jammed, and we basically capture it and take it out. And this is one of the recent clots that we have taken out from somebody's brain, where we just basically, using this device, we basically just suctioned it or clamped it and taken it out, and restarted blood flow to that part of the brain. So these two treatment is very critical in getting patients to the hospital on time. So the limits here is 4.5 hours. We can do this up to 24 hours now, thanks to all the research that we've done in stroke in the last, a decade. Before it used to be just 6 hours. Now we can do it up to 24 hours in certain patients. So regardless, time is brain. Now, we talked about hemorrhagic strokes as well. Hemorrhagic strokes just means bleeding in the brain. This illustration represents basically an aneurysm here. So aneurysm here, or outpouching of a blood vessel, that if it's within the blood, within the brain, it's called intracerebral hemorrhage or intraparenchymal hemorrhage. That just means the fancy term saying that it's inside the brain. Now, sometimes we can have aneurysms on the outlying of the brain tissue, which you see the brain tissue here, but this is a blood vessel that's overlaying the blood vessels, the brain. And with that, if that bursts, then we call it subarachnoid hemorrhage. That just means outside the brain. And basically, hemorrhagic strokes actually have very simple treatment. We reduce the blood pressure of the body really fast, because the more blood flow to this area, the more likelihood this bleeding will get worse. And then we also, if it gets to a point where it's causing more damage than it should, we also perform surgery to take that particular clot out or treat this aneurysm or this outpouching. Okay. So this map tells us in density of stroke death rates from 2015 to 17 in adults aged 35 plus by county. So it's just individualized county. And you can see here that in the Midwest, you don't have a whole lot of density of stroke. But here in the South and over on the East Coast, we actually have a lot of strokes. So per 100,000 people, we have close to 90 to 200 strokes. And these are deaths. These are not just strokes. So, and then here in California, we have a mixed pattern. Central California, we have a little higher rate than here in Orange County, and then basically. And it all depends on it may depend on the availability of resources, diet, and genetics as well. So quite heavy in the southern region of the United States. Okay, we actually call this a stroke belt of the United States. So in conclusion, stroke is actually can occur in any age. It doesn't, majority of my patients are elderly, but I have seen patients in their 30s, 20s that actually have strokes. Kids can actually have strokes as well, but it's very rare. Their risk factors are different in kids, but that's beyond the scope of this presentation. But it's just to highlight that it can occur in any age. Cryptogenic stroke is just a word to say that we just don't see an underlying cause. So, we looked at all these modifiable risk factors for stroke. Sometimes there are cases that we just can't find the cause, or we haven't found the atrial fibrillation. So we call it cryptogenic stroke just to give it that name until we look at all the risk factors, and then and sometimes we may not find it a cause of the stroke. And then we look secondary causes. Once we cannot find a primary cause of stroke, we look at more extensive causes of stroke, especially patients that are less than 55. Actually, I do more than 65. So, and then basically, in a nutshell, basically, you have to aggressively treat your secondary causes of stroke. Basically, what that means is blood pressure, cholesterol medications. And if we see that your risk for stroke is high, we preemptively start aspirin or Plavix to reduce your risk, and that reduces your risk quite significantly. Okay. And now I'm going to hand it over to Diana Tai.
Hi, everyone. Thank you, Dr. Rahim, for that very thorough lecture on obviously trying to educate the community as far as what you can do in regards to minimizing your risk for stroke. So this is one of the things that we do summarize here at Providence. This is what we talk to our patients all about, especially if they've come into our hospital with an actual stroke. We look at all of their risk factors, and a lot of the modifiable risk factors reduces your risk significantly. So with regards to either losing weight, diet, exercise, if you're smoking, because of the detrimental changes, as Dr. Rahim did discuss, on the vasculature, on those vessels, that smoking really hardens those vessels and makes perfusion to the brain and to the heart very, very difficult. Looking at your sodium intake, because high diets that are very heavily involved with sodium intake, that definitely increases your risk for hypertension, and salt, obviously water retention. Looking at a healthy diet, a lot of the times I get questions from family members and as far as patients, what kind of diet should I be looking at? And I think I eat pretty healthy. And, sometimes everyone can take a sugary snack here and there, but we're always looking for things that are in excess. So if you are in excess of alcohol intake, if you're in excess of sugary or fatty or high carbohydrate intake, that takes into consideration, and those compiled risk factors can definitely put you at a higher risk for developing cardiovascular and cerebrovascular disease. So looking at a healthy diet, Mediterranean, leafy green vegetables, be cautious if you are on a blood thinner, specifically Coumadin. But things that are high in like vitamin C, any of those fluid intake, increasing your amount of water intake is always great for the body. Exercise, talking to your primary care physician and seeing which exercise regimen would be appropriate for you. If you weren't running a marathon or running, 30 minutes a day, I don't anticipate you doing that in the next few weeks. It's always a gradual buildup. Do what your body dictates. So if your body's telling you, I am tired or I am a little bit fatigued, take it easy and then try again. Any exercise is good exercise. Walking around the block with your significant other, or taking a stroll with your pet. It doesn't matter as long as you're up and moving. So we always encourage you to get up, get moving, and always have your primary care physician help guide you in that. Looking at high blood pressure and watching your diet will definitely help with reduction of your blood pressure. If you have hypertension, the way that we always say with managing blood pressure is taking your blood pressure daily, keeping a daily log and kind of tracking to see what your trends are. Oftentimes we get patients that come into the hospital and their blood pressure is extremely high. And that's not really truly reflective of where they are at home. You know, they're coming in, they get white coat syndrome, they're in an unfamiliar environment, so their body is naturally going to respond to that stressful situation. But if you normally run 120s, 130s, that's great. You're right within where we want you to be in an outpatient setting. But always take your medications. If you are on prescribed medications for your blood pressure, you need to take them. We have patients that come in, you know, they say they try to manage their blood pressure medications and they forget one dose, and then the dose becomes, I forgot a few doses, and then it's going to be a lot harder for us to control that blood pressure in an acute setting. Looking at high cholesterol, getting your yearly checkups with your physician is very important, or your advanced practice provider is very important, because we're looking for changes in your vessels, making sure that we're looking at high cholesterol and getting a better control of that. So if you're on medications that are lipid lowering medications known as statins or Lipitor, Crestor, there's a ton of family members, ton of family medications like that. Please make sure that you're taking them accordingly and getting your lipid panels checked. Atrial fibrillation, so this is one of the biggest risk factors for our stroke patients that Dr. Rahim did allude to. That quivering of the atrium causes clots to build up, and that is a direct shoot up all the way to the brain. It can cause stroke. So if you are on blood thinners, knowing that your risk for stroke is never at a 0%, but compliance is key, making sure you're taking your blood thinner accordingly. And if you're on warfarin or Coumadin, you need to be very compliant in getting your blood draws to make sure that your blood is thin enough, because that tells me that your blood pressure, your anticoagulation is working. And then diabetes. Diabetes is one of the most common risk factors that we do see in the hospital setting in conjunction with hypertension. Diabetes is all about diet, exercise. You know, there are genetic predispositions that put you at a higher risk for developing diabetes, but control is key. So if you're doing a hemoglobin A1C and following up with your doctor, that hemoglobin A1C tells us whether or not you've been controlling your blood sugars for the past 3 months or 90 days. What you want that level to be is less than 6.5. So if you're hovering around 7 or 7.8 or even 10, I've seen them as high as 14. That tells me your blood sugars haven't been well controlled, and that puts you definitely at a higher risk for development of cerebrovascular or cardiovascular disease. So what we want to leave you with is looking at the acronym. Everyone has been educated on that FAST, that FAST acronym, but here at Providence, we really want to reinforce B FAST. B for balance, if you're experiencing any sudden balance issues. E for eyes, visual changes, blurred vision, double vision, things like that. Those are the B and E really tells us about what we look for, posterior signs, symptoms of stroke. That tells us that there's something's going on in the back of the brain. And then obviously the big signs, the face, if your face is kind of droopy, or if your arm is weak specifically on one side, or if your speech is, you're having speech disturbances, that means your body is saying, hey, you are having a stroke. Your body is telling you something is going wrong. I always say these are the signs and symptoms. This is similar to the chest pain before the heart attack. So this is kind of like the brain things that happen before the actual stroke. Don't wait. Don't think about it. Just immediately call 911. We'd rather you call 911 and we let us as the professionals at the hospital determine what's going on, so that way we can get to your brain, because time is brain. Every time a stroke happens, you know, brain cells die and brain cells aren't able to be regenerated. So it is very key that you get to the hospital, to the nearest stroke center as possible. And all of the EMS folks here in Orange County are designating or educated in taking or transferring these patients to the closest stroke facilities. So us being one of them down here in South County and at Providence Mission, there are many others. There are about 8 other hospitals that are our stroke receiving centers, and we are strategically placed so that we can provide the best care for stroke in our community. So on behalf of the stroke program here at Mission Hospital and of Dr. Rahim, we are extremely fortunate to be able to share this wonderful information with you, and we look forward to hearing your questions. Any feedback for us? If you wanted to see us dance or sing a song, we'd be happy to. Dr. Rahim mostly, but we look forward to hearing your questions at the very end. Thank you.
I want to see that dancing. Okay. Thank you, Dr. Rahim, Nurse Ty. Thank you so much. That's such a valuable topic and such useful information. All the facts, the interventions, very, very information. And so now if any of you have questions for our presenters, be sure to type them into the question box. We do have some questions that I'm going to direct to the presenter, but before I do, I want to just say, I want to take a minute to thank our sponsors in case we run over our time limit a little bit. So many, many thanks to our wonderful collaborators, Care Choices, Hospice and Palliative Services, O'Connor Mortuary, Caring Companions at Home, and of course, Alzheimer's Orange County. Remember that before we begin the Q&A, if we do run past 12:30, you're welcome to remain online to ask your question or to listen to the answers. But if you need to leave the webinar, of course you can. Just remember that if you're earning CE credit, that you do need to be online for that full 60 minutes. One last thing before we go to the Q&A is I want to remind everybody of next month's webinar, which is scheduled for Tuesday, September 14th. And the topic is transitioning to a memory care community. And our speaker is Dr. Jane Mahakian, and she is a local gerontologist and author who has been helping adults with cognitive impairment and their families for over 30 years. Okay, so with that, let me open up the question box and see what we have for our guests. Okay, our first question is, are strokes hereditary? And I'll just put the questions out there and either of you can answer them.
So that's an excellent question. I get that all the time with a lot of patients. We do look at family history of stroke. There are some types of stroke that are hereditary, and we look at bleeding complications or actually clotting disorders. So some people may have a disease that causes them to coagulate, which means clotting, much faster than the general population, and that increases your risk of stroke. There are other genetic causes of stroke which are very rare, but there is a correlation between, if let's say your parents had a stroke or your direct relatives have stroke at less than 65 and now, it does open up a bigger diagnostic tool for me, workup for me to see all your risk factors from that perspective. So there's a component.
Thank you. How often do you do an MRA of the head and neck?
How often?
That's a question, yeah.
How often do I do it?
Maybe she means it's a routine test.
Diagnostic.
Oh, yes. So basically, the MRA shows me the blood vessels of the brain. Now, I can do a CTA, which is a CT image. It looks at the blood vessel, or I can do the MRA. Sometimes when I have a little bit more time, the stroke is not, it's not happening right now, it's already occurred, I may do an MRA because that takes a longer time to do. But if I'm in a hurry to see what's going on in somebody's vasculature, then I will do a CTA instead. So MRA is less popular than a CTA because CTA is instant and I'll get the information within seconds. MRA can take up to an hour to do. So So, you know, when time is brain, MRA, even though it will give me more information, may not be the best diagnostic tool. So, but I do MRAs I can do without contrast. So if somebody has kidney dysfunction, I will do an MRA. So CTAs are more common than MRAs, but you know, I do, when I take care of, let's say, 10 patients a day, 1 or 2 of them will have an MRA.
Thank you. Does sleep apnea cause AFib?
Indirectly, yes. So sleep apnea, if you do stop breathing at night or you have decreased oxygenation, that puts stress on the heart over time. And when you have more stress to the heart is it basically adjusts itself to overcome that you know, the lack of oxygen that it provides, and it can lead to atrial fibrillation indirectly.
Thank you. How does overnight oxygenation increase stroke? Is it from increased heart rate?
Increased risk of stroke. So it's a lack of oxygenation actually. So if somebody has sleep apnea or constriction of their airflow, so they'll stop breathing, and then the brain. Sorry. Yeah. So basically, it will cause lack of oxygenation for that period of time, and that lack of oxygenation will put stress on the heart and then subsequently on other organs, including the brain. So having a CPAP for sleep apnea, having a patent or a clear airflow will reduce that pattern down the road. So CPAP is a second, it's not a major risk factor for stroke, but as you age, you know, we want to look at every risk factors you have for that stroke, and CPAP is one way that I approach it. Yes, or sleep apnea.
Thank you. And you've really addressed this already. The attendee is asking, do younger adults get strokes, men in their 20s and 30s? And you did say that even children can get strokes, although it's more rare. Is there anything you want to add to that?
Yeah, that's an excellent question. Yes. So majority of the people that I see younger either have a hereditary cause for stroke. A lot of substance abuse will cause stroke. Sickle cell, which is hereditary, causes stroke. So it's not the typical high blood pressure and the cholesterol, because those are something that the young population don't have a high incidence of. So I'll look at different causes. I'll check, have they been abusing drugs or something like this that can increase the risk for stroke. So yes, that is something I want to add to that. That there is something more than just high blood pressure and smoking, and that in young ones that I look for.
Okay, thank you. When I hyperextended my neck, I felt dizzy and seen stars. Can it be from vertebrae artery insufficiency? Children nowadays look at their phone for a long time. Will that cause any problem with carotid or vertebral artery later in life?
It's a two-part question. So
Okay.
yeah, extending your arm, it depends on how you extended it.
Neck.
Usually your vertebral artery is very durable to neck flexion. However,
Okay.
I do see it when sometimes when somebody goes for neck manipulation for a chiropractor, they can injure the blood vessel, and that can cause strokes. And if you repeatedly, let's say you raise your arm up a particular way, and every time you did that, it caused a neurological deficit or stars or whatnot, that's indicated of vertebral insufficiency. Vertebral insufficiency for the rest of the audience just means that you don't have enough blood flow to one of the blood vessels. You have 4 blood vessels. The one of the back ones is getting reduced blood flow. And that could be a sign, but it has to be repeated. It may or may not, you know, depending on the context of that scenario, it may require us to do more testing. And I'm sorry, what was the second question?
Just asking about children nowadays looking at their phones all the time.
yes.
Is that likely to cause any problems with carotid or vertebral artery later on in life?
I don't see a correlation. There's no studies that have shown that, but I do tell my kids to get off that phone also. So, but yeah, I mean, I don't see a correlation at this point.
Okay. That's a huge relief. Is there any reason there is a higher stroke density in the East Coast? And you did talk a little bit about
Yeah,
that
so it's a diet. It's a
diet,
diet.
yeah.
It's the genetics. You have, in that population, you have more African Americans. You have poor, and then also I mean, the resources are there. It may be the it's not the resources of getting to a doctor. It's the lack of people going to the doctor as well or being educated. So genetics plays a role. The diet plays a role in all that. So that's why the density is higher.
And African Americans get uneven treatment in the healthcare system. And I would
Right.
imagine that's true, especially maybe more true in the South. I don't know.
So from a stroke perspective, we recognize that, and there have been a lot more you know financial assistance to those hospitals down there to highlight the risk of stroke, and and to get them the proper education, the physicians, the education, the resources to combat that. But it's work in progress, and
Right.
education is part of it. Just like we're doing here, a lot of physicians, a lot of healthcare workers, and nurses, they'll go out in the community and educate. So education is the first line of defense for us.
Right. Those modifiable lifestyle factors that
Exactly.
are tough to
Yeah.
to teach. Yeah, got it. Great. Okay, I've heard about a mobile stroke unit on the ambulance, which saves time. Will that be available in the Orange County area anytime soon? A mobile stroke unit.
That's pretty specific. Good question, actually. So we are looking into the logistics of providing that for our community as well. Unfortunately, in we have to in medicine we have to portray the need for one, and then that's what we're working on here. That a mobile stroke unit, especially from Mission Hospital or Providence, would reduce the risk of stroke. Our the issue with Orange County is there's a lot of stroke centers here. So you're within a 10, 15 minutes for any stroke center. So that's what stands in our way, but we are working towards getting that. Yes.
Great. So the normal range for blood pressure should be about 140 over 90 or less than 140 over 90?
Correct. And in diabetes and patients with uncontrolled diabetes, we actually like a little bit lower, 130s over 80s. So,
Okay.
but generally for this presentation, for everybody, it should be 140 over 90.
Okay. We have a few more minutes and a few more questions, so I'm going to ask them a little bit more quickly. When you talk about substance abuse factor for stroke, does that include cannabis or marijuana? So is marijuana a factor for stroke?
Marijuana, it's not. It's the smoking, the actual damage to the lungs that does play a role. No matter it's cigarettes. Cigarettes has a nicotine component to it that also adds, but the smoking, it does increase your risk.
Okay. What is recommended to do after a stroke? Like the bystander.
A bystander, let's say if you witness somebody having a stroke, the best thing to do is call 911 and tell them that you recognize these, that recognize a stroke, so they can get the appropriate, EMS to you, and they can take you to a stroke receiving center. So that's the most. Just recognizing it is step one, and calling the 911 right away.
Thank you. Oh, here we go. What is your opinion, Dr. Red wine or a scotch daily to reduce the risk of high blood cholesterol? Well, I don't know, high blood pressure or cholesterol. Yeah.
I get that question all the time, but red wine and moderation actually does help your good cholesterol, which also lowers your bad cholesterol. But like Diana Tai said that in excess anything is going to cause issues. So in a small moderate amount, we see that a glass of wine, it's good for the heart. It's also good for the brain, but in moderation. But I've seen that meme where the glass is like this big, so that may not help. Small glass helps.
Okay. All right. Let's see if there's one more. The final question is just, can you just say a little bit about AFib?
So atrial fibrillation is something that we see in a lot of patients that come with strokes. Unfortunately, people who have AFib and develop a stroke, those strokes are much, much worse than the strokes that can be caused by hypertension and diabetes. Because those are more of a clot formation in the heart, and those clots are bigger than something that high blood pressure or diabetes can produce, and those cause lack of blood flow to majority of the brain, and those strokes are much, much more serious. But fortunately, we have these devices that actually go after those clots and retrieve them. So atrial fibrillation, keep your heart healthy. Subsequently, keep your brain healthy as well. So having a cardiologist, if you have atrial fibrillation, manage your blood thinners is the best way to approach atrial fibrillation. Unfortunately, a lot of people live with atrial fibrillation, but only a fraction of those, very small fraction, come with strokes.
Thank you. Okay, that does bring us to the conclusion of our webinar. And of course, we want to thank both our presenters, Dr. Rahim and Nurse Tai, for sharing their time and expertise with us. Please, everyone, as I close out the webinar, the survey will pop up on your screen. You can go ahead and complete that. It'll also be emailed to you within an hour after the webinar ends. Watch for our flyer for the next webinar on transitioning to a memory care community, scheduled for Tuesday, September 14th. And don't forget, you can always visit our website at www.alzoc.org to find out more about our education programs, webinars, and to view recordings of past webinars in our virtual library. Thanks to everyone, and have a wonderful day. Take care, and once again, we thank our sponsors as well as our wonderful presenters today. Goodbye.